Hi, and welcome to Chapter 2. This is Personal Safety and Wellness. This one can get a little bit redundant. So instead of beating the dead horse of how we should be taking better care of ourselves because we know how, I'm going to focus more so on how this is applicable to Western North Carolina, as well as add a few tips and tricks for the IBSC certification test. So we're talking about providing care for patients. So some of the most important things that we do always focus on in the field is scene safety. We know about checking for highway incident scene issues or stepping into homes and the things that we run into. The difference is that we're in these environments for extended amount of time. So we're going to be in homes, barns, even sheds where patients live or work. We're still going to have to encounter those aggressive pets, loose floorboards, hoarding hazards, environmental dangers like propane heaters. Just know that we're going to be there for longer, so planning ahead is going to be key. We're also going to talk about being an example of wellness for us as providers. This goes beyond not being sick, but goes to needing the physical stamina to hike up the long gravel driveways with our gear, the mental clarity to remember medication lists without a computer in front of us, and the emotional bandwidth to deal with the complex patient situations that you will indeed find yourself in. So the IBSC does expect you to understand that provider readiness directly affects patient outcomes, especially in those prolonged one-on-one home visits. There are four main components to well-being: physical, mental, emotional, and spiritual, and these all play a role within our effectiveness as a provider. So in Western North Carolina, emotional resilience might be tested by isolation during those long rural calls, or spiritual well-being might be supported by community involvement, faith, or outdoor activities within the mountains. So for a testing tie-in, be able to identify how neglecting any of the four areas can lead to provider burnout and then lead to reduced care quality for our patients. The AHA, we're all familiar with AHA. They have Life's Simple 7. That's activity, cholesterol, diet, BP, weight, blood sugar, and no tobacco. So these are also testables as well. So in Western North Carolina, we might be applying this knowledge when we're helping a CHF patient manage salt intake, or explaining why blood pressure checks matter to someone who's never even been to a primary care provider before. Also, if we're going to talk to patients about diet and exercise, we can't live on Bojangle biscuits and 3 energy drinks a shift. I'm just going to throw that one out there. Nutrition, it affects everything from cognitive to wound healing within our body. So we may encounter patients in our area and their main grocery store is the Dollar General. This is going to change your approach. So you may need to teach labeling, so how to read labels and choosing the healthiest available options rather than expecting for them to have access to fresh produce. And we are all familiar with the myplate.gov. The USDA guidelines on food groups and portion sizes aren't just academic. In the home care setting, you may be coaching patients to balance meals with what's realistically in their pantry. And sometimes it's not a lot. We may have a scenario where we have to recommend portion control with very limited food options and try to find balance with what they have on site. Our physical well-being. So managing our energy is so important as a CCP. These positions are often on the road all day long. They may have limited access to healthy food, so pre-pack, pre-game your healthy snacks, hydrate and manage your caffeine so you're alert but you're not jittery and cracked out. So an example like Madison County, if you were running up Madison County and you have multiple home visits, then your lunch break might be a sandwich in a church parking lot between stops. So plan ahead and it will keep you from skipping meals and keep your energy levels manageable. Weight control is about sustainable changes. It's not the crash fad diets, as much as we'd love it to be. It's the small things that lead to the big changes. So as a CCP, we're going to be coaching patients who are overweight. They may have limited mobility. So we're going to have to tailor our strategies to their home settings, like maybe suggesting small dietary swaps and short, frequent movement breaks rather than high impact exercise. People tend to, I guess, fear the end goal, or they think too much about that end goal. So instead of thinking about how am I going to get to this big end goal at the end, what are these little manageable steps that I can do that are going to get me to this big end goal? So proper goal setting is very key to seeing success. Exercise. We know it improves sleep, reduces stress, and it boosts our long-term health. Our job is physically demanding. We know this. We're climbing stairs, lifting equipment, moving patients in the tight spaces. That's a part of CCP too. So staying fit keeps you safe and sets an example for your patients, and it also helps keep you from becoming injured as well. They recommend about 30 minutes a day of activity. That's the standard. So our goal, though, for our patients is trying to find ways to make this achievable. Maybe they've never even entertained putting exercise into the routine. So we're going to make some small recommendations. So seated exercises for balance impaired patients. So goal setting. So between now and next week, when I'm back here visiting you, I want you to be able to complete 4 leg lifts and 2 kickbacks, or whatever it is that you come up with the patient, but make it very defined, very small, and very obtainable. Consider indoor walking in the winter months if that is a barrier, or light yard work for those who enjoy being outdoors, such as raking leaves. Tobacco, smoking, vaping. Don't start. If you haven't started, don't start. Tobacco use counseling is part of our chronic disease management that we do in the field. So one challenge that we have in Western North Carolina is that we do still have tobacco farming. And so this is a part of their culture. So when you're approaching cessation conversations respectfully, so we're going to be focusing on health benefits without being judgmental. Community paramedicine requires adaptability, emotional control, and also being open to new roles. It is very different from what we've done on the 911 side. So you're going to need to expect test items around emotional intelligence, self-regulation, especially when dealing with challenging patients. Recognizing emotional control strategies and adapting communication for patient education is very key, and setting this up before you have that difficult patient. Work-life balance. It's hard for any of us to find in public safety, but even more so, I think, for the CCP. Your burnout can come from emotional overload in long-term patient relationships. These patients may also become socially attached to you, so you've got to set some clear boundaries and guidelines, but you still have to find ways to keep that compassion. It is a lot different than just getting a signature and dropping them in the ER. It's hard to not form those bonds in the attachment. Respect for diverse beliefs is very key and essential. We may be invited to faith-based activities by our patients, so keep that professionalism, remain supportive and respectful of their beliefs, but also maintain your role boundaries. As a CCP, treat and release is now replaced with assess, educate, and follow up. The IBSC may test on identifying when patient education is the primary intervention. They do want that to be enforced, that patient education is huge. Also, we need to assess our weight, nutrition, and activity, and then make realistic recommendations, encouraging gentle activity for someone who heats with wood, maybe as simple as chopping kindling. That does count. So think about the realistic things that they could do to help maintain. We're going to be addressing risk factors like tobacco, alcohol, drugs, sleep deprivation, and stress. Sleep issues might stem from a multitude of things, from caring for livestock. Maybe they do shift work, or they have a family that they are the main caregiver of. So try to find some ways to set up boundaries or barriers. We know that these are barriers, but set up ways to get around these barriers. We talk about stress a good bit in the field. With this one, there's 12 slides on stress specifically, so it is a huge topic with CCP. let's talk about eustress real quick. Eustress is the opposite. It is the good stress. That is what motivates us. It's like the adrenaline you feel when you're piecing together a complex care plan and realizing that we actually did make a difference for this patient, that they got something out of it. The distress is the bad stress. That is what hinders our performance. So a patient canceling visits repeatedly and their conditioning worsen is an example of that. So in the 911 field, we thrive on the short burst of eustress. We stabilize the patient, we hand off, and we reset for that next call. In CCP work, the call can last for weeks or months, so you'll need to find motivation in small wins over time, rather than that instant gratification of saving a life in 20 minutes. Once again, it's the small wins, the small steps that get to the big change at the end, and that gratification for them too. Our IBSC may present case-based questions where you have to determine whether stress is motivating or hindering your ability to complete a patient's care plan. We have stress triggers in CCP as well. It often can look very different than what we see in 911. So instead of our chaotic trauma scenes, we're going to be facing complex family dynamics, like when multiple relatives disagree on the patient's care plan. We want the families involved. We want them to be part of their plan. That is their support system, but it can be very challenging. We know families don't always get along or agree, and some definitely put the fun in dysfunctional. So that's one of the things we need to keep in mind. Resources can be scarce as well. The nearest specialist may be 2 counties away, or there's no reliable transportation. Multi-agency navigation may be needed, so coordinating between home health, primary care, social services, and our own program. So on the truck, we're used to MacGyvering. We solve problems. We solve problems quick. We get it done. In the home health setting, solutions may take weeks to coordinate. So patience, documentation, and follow-up are key. Skills that will get tested on the IBSC as well. Fight or flight isn't just for the MVCs or our active scenes. We may feel in this role that same surge if you walk into an unsafe home. There may be an aggressive dog, weapons, maybe signs of drug activity. So in 911, we back out. Scene not safe. We're going to call law enforcement, right? Leave, scene not safe. So in CCP work, you still prioritize safety, but you may also need to pre-plan for safety before visits. So coordinate with law enforcement discreetly. Make sure that it's not a home that has been flagged previously, or adjust your approach for trust building with that patient. So for testing environments, they may give you a scenario where a patient's home environment is unsafe, and know the steps to secure your safety and maintain that patient relationship as well. Our cumulative stress is the slow building stress that we get. So in CCP, it tends to sneak up on you. And that's after months of dealing with the same barriers. We may have resistant patients or seeing preventable decline. Our street providers, we often process a call, we move on. In CCP work, you see the same patients over and over and over. And those struggles can weigh heavier on you and sit harder in your heart over time. So please recognize this early. That'll help you set boundaries, use our peer support system, talk to someone who's been working in this field for a while and may have some healthy things put into place to help them manage. Also, rotate challenging caseloads. You may have several very difficult patients on your plate at one time. Maybe another person that works in the same program as you doesn't have quite the heavy load. They have easier patients. So maybe see if you can mix and match. Maybe trade some of your heavy caseloads for some lighter patient ones. Our test likes to ask how you identify and address cumulative stress before it leads to burnout. So reactions to stressful situation. Our patients may react with fear, anxiety, or anger when discussing these lifestyle changes. So fear could be, if I change my diet, I'm going to get weak. I don't want to change what I eat because I need this energy. Anxiety, I can't afford these medications. I'm on a fixed income. She keeps saying I need to take the meds, but I have no money. And anger, you're telling me I'm doing it wrong. No one likes to be told they're wrong, and people sometimes do react very aggressively when you call them out on it. So in our 911 work, emotions are often driven by the immediate crisis. In CCP, emotions may be tied to loss of control or the fear of change. Change is scary. So our role is to keep the conversation goal focused, the little small changes. It's not looking at the end goal. It's what can you do about it today? Keep them calm and always remain empathetic. We do have different reactions like defense mechanisms that are common, denial. So my sugar's fine. I don't know what's wrong with your meter. My sugar's just fine, even though it says 400. So projection, blaming family members for the missed appointments that they haven't been able to attend. They don't want to accept that blame, so they put it on somebody else. Or displacement, snapping at you because they're frustrated with the healthcare system. That one is probably pretty common for all of us these days. Other things, weather, roads, rural access can get blamed a lot, which they're valid, but we need to put that gentle redirection in there to try to focus on solutions instead of the excuses. With our test scenarios, expect scenario questions on how to respond constructively without alienating the patient. Culture reactions to illness and care do vary. So in our area, we're probably going to see some strong independence. So they don't call 911 until they're dying in my neck of the woods. So you're going to have that reluctance to accept outside help. Maybe faith-based decision-making. We have a lot of different faith-based communities in Western Carolina. So choices may be filtered through church or family elders. There's also a huge distrust of the system these days. So make sure we're building rapport before we make recommendations. People don't care about what you know until they know that you care. So build the rapport. IBSC likes to test your ability to adapt communication styles to our different cultural norms. Family members may become stressed during home visits as well, especially if they are the caregiver. They may feel like you're judging them. They may feel overwhelmed or excluded from the decision making. So in EMS, we do have family members that are there. Most of the time they are bystanders or history givers, and we only see them for a brief amount of time. In CCP, they're a part of our care team. So sometimes our job is to manage the entire room, not just the patient. So we want the family to be involved. We don't want to alienate the family, so we need to make sure we're building rapport with them that will last. That way our visits stay productive. Self-awareness is also critical. How we are presenting ourselves to the room is key. I find most providers, we do a pretty good job of this, although I've met a few that are not as aware. But if you're tense, distracted, or short-tempered before a visit, it's going to affect how that patient responds to you. They're going to basically put back what you're giving out. So in 911, if we have a call and we're in a bad mood, calls 20 minutes, we can kind of mask it. It's easier with that short time frame. With this line of work, we may be in the home for an hour or two, and it's a lot harder to hide the bad attitude. So try to develop pre-visit reset strategies for yourself. That way you can put yourself in check. Stress management techniques are also key for working in the home, just like we do on scene. So controlled breathing, the deep breaths in and out through your mouth. So in through your nose, out through your mouth. Controlled breathing before a difficult conversation is great. Grounding techniques if you feel triggered by the environment. Think of find one thing that's purple, one thing that's silver, or touch something that's cold, or one thing that's hot. Focus on the immediate goal, the immediate, not the long-term goal, but what the goal is right now. So also, which technique is most effective for de-escalating yourself before interacting with the patient? That's something I want you guys to ask before you get into the field. If you find yourself in that situation, how can you de-escalate yourself before you get into that room with the patient and their family? We have burnout with this CCP role as well. So That may mean doing some work ahead of time, rotating duties if possible, scheduling regular breaks between visits, keeping some non-patient days for documentation and planning, as well as engaging in activity outside of work. We all need our non-911 friends. So unlike our shift-based EMS, CCP work can blur much more into your personal time. So boundaries need to be set. That way you're not always on. We also have PTSD and CCP, and I love that they are making this more of a focus within our materials within paramedicine in general. So PTSD in this field or in CCP is not always from violent scenes, but from repeated exposure to patient decline, traumatic events in the home, or safety threats. So in emergency response, we expect critical incidents to trigger the PTSD, and CCP, that trauma is quieter and it's cumulative. It's the small things that add up. So pay attention to early signs with yourself, like avoidance of certain patients, intrusive thoughts, or withdrawal from coworkers. There are some testables in PTSD. They may want you to recognize PTSD in both providers as well as patients and appropriate referral paths for both. Infectious and communicable diseases. So disease transmission is definitely a big focus within this line of work as well. We know infectious diseases are caused by harmful organisms within the body, and communicable diseases can spread from person to person. When we're in the home healthcare environment, exposure risk is different than when you're on a truck. You might be spending a large amount of time with this patient in a very small, poor ventilated environment during cold and flu season, full of smoke as well. And then we're going to be visiting multiple high-risk elderly patients in that very same day. So being able to make sure that we are deconning ourselves, we're wearing the proper PPE is very key. So you do need to tell the difference between infectious and communicable diseases in case-based questions. Also, especially in patient education scenarios where you have to explain why isolation or hygiene is important. Reduce risk with your immunization, protective techniques, and hand washing. We all know hand washing is key. Just wash your filthy hands. Your work often takes you into homes without easy access to running water, though. You may not even have someone who has running water, especially in more rural settings or older houses. So carry things with you, alcohol-based hand sanitizers, sandy wipes, things like that. But no situations where soap and water are required. So visible soil, C. diff, hand sanitizer isn't really going to be the best thing. So try to find ways, bring some little things of soap with you maybe. For testing purposes, they may ask you to choose the best infection control method given a specific exposure or pathogen. Mechanisms of transmission still the same. We've got direct, indirect, airborne, foodborne, vector. You guys should know the differences between these and how this can occur. You may have to match the scenario to the transmission route within your testables. Having a solid understanding of PPE for each transmission route is very key as well. If we're visiting multiple homebound patients in flu season, put a mask on us and put a mask on them. Don't forget PPE. Always do your PPE. The IBSE does like to ask questions about what the minimum PPE is for suspected pathogens. For risk in our homes, pathogens, sharps, unsafe surfaces, we may have someone who's a diabetic. They have used needles on tables or broken glass on floors, pets that aren't contained. So scan your surroundings before you sit down or you put your equipment down as well. Look for those ever-friendly bed bugs. So IBSC testing tip. Questions often test hazard recognition in the non-clinical environment. Stay up to date with immunizations as well. We're working with vulnerable populations and we can't afford to be bringing in any illnesses into our homebound patients' environment. So stay up to date with those. Our PPE basics, gloves, hand washing, lotion to prevent skin breakdown. We're going to be washing our hands in patients' sinks. So maybe dirty, nasty sinks. So be prepared. They may not have any soap or paper towels. So come prepared with your own supplies. For eye protection and mask for droplet precaution, We may have coughing patients that are in very close quarters that will put us at risk. So wearing a mask in a home may feel less routine, and we may have a tendency to not want to do it than we would in a hospital, but it's just as important. For tests, identify which precautions are needed for illnesses like influenza or pertussis. Protect your body with appropriate clothing and gowns. I don't know anybody that carries a full gown around. Kudos to you if you do, but at least make sure that you have an extra change of clothes if the need arises. So keep that in mind too, friends. Keep your N95 with you, get fit tested regularly, and have a spare N95. Also remember to decon between homes. That's for your BP, cuff for your stethoscope, pulse ox, and whatever else you are carrying in with you. Always dispose of sharps appropriately and ask your patients where their safe disposal areas are, and also educate them if you need to. The test also likes to make sure you know what the first action is if you do have an accidental needle stick in the field. So we are almost done with this lecture. Just got one more thing to really focus on here, and that is talking about hostile situations. So in 2003, the National Association of EMS Physicians outlined for the first time an official endorsement of the rights to safety for patients and their field caregivers. If the element of hostility is known or can be anticipated in advance, you should never be allowed to arrive on scene first. So scrutinize all information and keep yourself on yellow alert when on duty. Be aware of any situation that has the potential for violence, shouting, abusive language, threatening gestures before, during, and after you provide care. You can ask for law enforcement whenever your intuition suggests that violence could happen. Listen to your gut. You guys are all experienced. Know that gut instinct and act on it. So once in contact with a hostile patient, concentrate on de-escalating. Try to de-escalate first. Remember, in rural areas, which is where we are, you may be alone or far away from law enforcement, so trust your gut. Keep an exit route in mind and disengage early if safety is questionable. Know when to withdraw, request law enforcement, and document the encounter. Last but certainly not least would be body mechanics. So minimize total body lifts, coordinate with your partner, use your legs, keep the load close. We all know that. Ask for help. Many home settings have tight spaces and uneven floors. We're used to working in these environments, but plan lists before moving the patient. For our heavier patients, identify assistive devices in the home. These are huge testables right here. Walker, the gait belts, and the Hoyer lift. Know them, know what they're used for, and use them in the field. And that's wrapping up chapter number 2. I hope that was helpful, and you all keep it safe out there.